We're moving on to the next keynote address by Dr. Suresh Kattera on the topic Redefining Male Factor Infertility, Ultra Rapid Sperm DNA Fragmentation Testing, and Gentle Sperm Selection. Dr. Suresh Kattera is a scientific director at Pearl Singapore Fertility Center and Research Institute. He's reported the world's first birth after enucleation of tripronucleus zygotes using his ICSI skills, which is published in the prestigious journal. Welcome, sir. Over to you.
We are almost at the fag end of the day. I hope to hold the audience. Please bear with me. Good evening, everyone. Thank you, Dr. Jayakrishnan, for your kind invitation to speak here today. I'll be talking on redefining male factor infertility with a special reference to ultra-rapid DNA fragmentation testing and gentle sperm selection. Why male factor needs redefinition? Is a traditional semen analysis is enough. We know that sperm has to play two roles. One, it has to fertilize on its own unless otherwise somebody is assisting the sperm to get into the egg. The second is to deliver the paternal DNA. The question is, does sperm count, motility, and morphology can predict DNA fragmentation? The problem is the hidden factor is the sperm DNA fragmentation. As we all know, sperm DNA fragmentation is strongly linked to fragmentation of embryos, poor quality blastocysts, miscarriage, and IVF failure. So what is sperm DNA fragmentation? We all believe just doing sperm DNA fragmentation without realizing there can be single strand breaks, double strand breaks, oxidative lesions, chromatin protamine defects. The key concept is double strand breaks are more severe and more predictive of embryo failure. And we have seen this in our routine clinical practice. Why double strand breaks matter clinically? If you look at it, single strand breaks are often repairable. It has a variable outcome. We do, in such cases, when the patients agree, intervention of testicular biopsy. And when we have compared ejaculated to the testicular biopsy samples, the outcome remains the same. We don't see any fragmentation. Is it because of single strands? And oocyte has the ability to repair such single strand breaks. If you look at the double strand breaks, it cannot be repaired and it results in poor blastocysts and miscarriage. If you look at the historical evolution, in the 90s, we used to perform what is called the acridine orange test using a fluorescent microscope. And for the next 5-10 years, there was no interest to look at DNA fragmentation until early 2003, when Fernandez et al. In Spain published the first paper on sperm chromatin dispersion test. And a company called Halotech first introduced the test kit in 2006. As I was mentioning earlier in the other hall, that back in Singapore, we did more than 5,000 sperm DNA fragmentation determinations. And we found that about 10% of normospermic men had a higher DNA fragmentation index, where we consider 30% and above is clinically significant. And it was more associated with poor quality semen samples. Of course, SED is not a very reliable test as compared to tunnel assay, comet assay, and SCSA. However, the ease of doing compared to the remaining methods is much easier. So, sperm chromatin dispersion test has been widely used all over the world now, and there is always a debate whether we have to do it for all the patients or certain patients where there are indications. Why SAD became popular? Because it is simple. I wouldn't say it's really affordable. The kits that are available in the market, it's easy to interpret. It is lab friendly. You don't need expensive equipment. And it is good for fertility centers. The limitation is that it cannot differentiate between single and double strand DNA breaks. Now, we have been working on in our laboratory. I have some interest in this, trying to develop an ultra-rapid method. If you look at the traditional kits that are available in the market, it takes anywhere from 45 minutes to 60 minutes, and at times it could be even 2 hours to get a report. So as a clinician, for you, without the report, to make a decision on any intervention, the patient will be waiting, and you may ask the patient to come on some other time actually. Now the ultra-rapid goal is actually, when we have been doing this work for the past 1 year, we have been able to develop a test where even before someone completes a semen analysis, you can finish a sperm DNA fragmentation test, which takes just 6 to 8 minutes. If you look here, we have cut short some of these steps. Instead of waiting for 45 minutes minimum with other test kits, you will be able to finish this in 6 to 8 minutes. So during the same visit, if the report is available in 6 to 8 minutes, you will be able to counsel the patient. You will be able to decide on the intervention. And for the laboratory, you can decide what is the intervention, whether it is invasive or any one of those laboratory interventions. You can select better sperms, and you have an improved, particularly for a busy laboratory, better efficiency. Now we know that there are major pathways when sperm DNA fragmentation occurs: oxidative stress, apoptosis, protamine deficiency, and chromosomal fragmentation. If you look at the protamine deficiency, the ratio between histone and protamine is important to tightly package the chromatin, without which the chromatin will be unstable and it is at risk of increased ROS vulnerability, which in turn causes DNA fragmentation. Now, when you look at the embryos that we culture in the laboratory, if it is a single strand DNA, who repairs it? It is the oocyte. It repairs the paternal DNA, removes protamine, histone replacement, and the maternal DNA pathway is activated. However, the repair depends on the oocyte quality. Now, what is the repair window? It is during the first 12 hours of fertilization pronuclear stage. Repair is possible if it is single strand break, mild oxidative damage, and limited double strand breaks. Poorly repairable if there is extensive double strand breaks and severe chromosomal damage. Now, you might have seen actually in the laboratory, we do see the first 3 days, the embryos look clean without any fragmentation. During this period, maternal transcripts dominate and embryo looks beautiful. At the end of the 5th day, you may not see a good quality blastocyst. Why this happens? At day 3, embryo must use paternal genome. If paternal DNA is damaged, there is a failed transcription, delayed compaction. Even if it compacts, it will not form blastocysts, which we have observed using time-lapse incubators and poor quality blastocysts. So, if you look at the classic pattern, day 2, good cleavage, day 3, good morphology, day 4, delayed compaction, and day 5, poor quality blastocysts. Now, if you look at the role of oxidative stress, what are the sources of ROS, which in turn causes DNA fragmentation? The sperm mitochondria, culture medium itself, light exposure, oxygen tension. And the ROS causes, of course, DNA fragmentation, mitochondrial dysfunction, and apoptosis. We know that you give a course of antioxidants, but it cannot directly repair DNA fragmentation, which is double strand breaks. It can prevent further damage. It can protect mitochondria. It can also improve repair environment, not the double strand breaks. Now, the second part, if you have to look at gentle sperm selection, you already know that IMSI is one such intervention, and still the intervention that we use, it hasn't been proved. The jury is still out because there is no agreement on the use of IMSI. And we know about microfluidics. You know about the PIXI that's used to select spermatozoa that are not DNA fragmented. And here I want to mention, apart from testicular sperm that we use in higher DNA fragmentation index cases. And here I just want to show you, this is one of the earlier devices I developed way back in 2006, which I mentioned in the other hall, where centrifugation per se causes DNA fragmentation. So we developed a method and a device where we separate motile sperms without centrifugation, and then the same sperm is used, initially meant for IUI. And many people have used, some of those who are in the audience probably have used, and they've seen a higher success rate as compared to the regular centrifugation methods. And we have seen a higher live birth rate and reduced miscarriage rates in these patients. We have developed a modified one. I just want to show you here. It's called the SEPD semen processing device. It comes with a filter actually. It will filter, it's a 10 micron filter. The sperms will swim into the top part of the medium, and from the top you aspirate and use it, either for any one of these ART procedures, IUI, IVF, or ICSI. So this will reduce the DNA fragmentation almost to 0% and increases the efficiency of the embryo quality. Why genital selection matters? As I already mentioned, traditional centrifugation, there is an increase in ROS, reactive oxygen species, which binds on sperm head. It has a higher affinity as compared to other cells because of the polyunsaturated fatty acids. So the DNA damage occurs in the sperm head. If it is a gentle method, there is a less ROS and better DNA integrity. Are there methods to detect double-strand DNA breaks? There are a couple of methods which cannot be routinely utilized, but it can be done, but you need expensive equipment. You have a neutral comet assay and pulsed field gel electrolysis. So the future could be a combined ultra-rapid SCD test and DSP validation. How this can be done actually. So what is the proposal here actually? If you have to redefine male factor infertility, you do a semen analysis, but it doesn't tell you, what is the DNA fragmentation. So you can do a DNA fragmentation, but the efficiency can be used by using ultra-rapid test. You have to do DNA double-strand break stratification and genital sperm selection and embryo protective culture. Now I want to show here, we only look at when you do a DNA fragmentation for large halo, medium halo, small halo, and no halo. But what we miss here is actually deformed sperm head. That's an indication of double-strand breaks. So considering this, what we are proposing is actually this classification where the degraded nucleus is included. And then if you calculate the DNA fragmentation index, which is more than, and then you make a decision whether a particular intervention should be used or not. Because any intervention, if you're not able to differentiate between single-strand breaks and double-strand breaks, there is no point doing invasive interventions like testicular sperm usage. Even laboratory interventions like PIXI or other devices to separate this will be costly for the patient. So we need to identify double-strand DNA breaks, and at this time it's only possible looking at these deformed sperms. Apart from this, these are the causes for poor quality blastocys. What else contributes actually? If you look at from the time of oocyte retrieval until we freeze and warm the embryos, the embryo undergoes lots of stress. We call it osmotic stress, and whatever I have spoken now is called the oxidative stress. We are able to almost take care of the oxidative stress. We are not taken care of the osmotic stress that happens, taking out the embryos in and out, temperature fluctuation, pH fluctuation. So many times during vitrification, warming, the embryo undergoes lots of changes actually. Something we have been working on during the last 1 year. I just want to show you this time-lapse picture. We always believe that blastocys will form only on day 5. If you take care of the osmotic stress, you can get earlier expanded blastocys. I'm not talking about early blastocys on day 4, expanded blastocys on day 4 late evening. And we have frozen these embryos. Even in the mice, experiments, what we have done, on day 4 only you will get, expanded blosses. But we get, with a modified, system, on day 3 itself, actually. So this time-lapse video I want to play here. On the left is day 5 blosses, on the right is day 4 blosses. You can see cavity formation starts at 74 hours, and the expanded blosses, which is day 4, and 94 hours. Now we have, using a modified culture system, we have seen 45% of the embryos will form expanded blosses on day 4 itself. And if we vitrify and transfer, they have higher implantation potential. So which means we are saving 1 day for the embryo. We are saving the stress by 1 day and helping them to implant better, actually. This is a comparison with this media, the one we developed, with a couple of other brands, actually. If you see here, there is 45% blossylation rate, expanded blosses, as compared to the other 2 brands, where you get only 9% and 6.6%. So there are 3 things to look at here, actually. Early blosses formation, better quality embryos, and good amount of inner cell mass. This is a table from another center which is currently doing this study, and they have compared and then seen, actually 75% expanded blosses on day 4. So what are we saying here? Earlier biological readiness of the blosses, higher implantation versus day 5, and workflow optimization. So the future of malar infertility is rapid testing, identification of double-strand breaks so that you can get better quality embryos and good number of blosses, at the same time reducing the osmotic stress so that you can achieve more than 80-90% blosses and good quality blosses. Personalized sperm selection, and then of course preventing the oxidative care. So what is the take-home message? Male infertility is no longer just count, motility and morphology. DNA integrity, chromatin quality, sperm selection and embryo resilience. Ultra-rapid sperm DNA testing may transform male infertility from reactive treatment to proactive treatment. With this, I would like to conclude my lecture. Thank you for your attention.